So hi everyone, thank you for coming today. My name is Matea. I'm one of the organizers of the challenge and I'm part of the Cancer Digital Intelligence program. So today is our clinical session. We're fortunate enough to have two presenters. So Dr. Andrea McNiven is a medical physicist at the Princess Margaret Cancer Centre. She is the lead medical physicist for the head and neck site group. So she's very familiar with the type of data that you are all going to be working with and the importance of it. And secondly, we have Joseph Marcilla, who I believe you all met last week at the technical session. And so today we're going to be giving you a bit of a clinical motivation for the challenge and why it's important and how this data could actually be used going forward.
So thanks again for the introduction and thanks for giving the opportunity to speak to you guys today. So the outline, I'm going to briefly give an overview of the radiotherapy process in general, just to provide some context for the challenge and how the contours are used clinically, and specifically dive a bit more into head and neck radiotherapy and some of the unique challenges associated with segmentation or contouring in that context. And very briefly, what is the role of automation for segmentation in our clinical processes? So to overview kind of the radiation therapy treatment process in general, we begin with kind of the decision to treat, and that's the initiation by the radiation oncologist that radiation therapy will be one of the modalities used. And the first step in generating a treatment plan is to obtain an image of the patient, typically CT simulation, in the treatment position they'll be treated in daily. Those images then move forward to the treatment planning system, where a radiation therapist or dosimetrist will take the contours generated typically by the oncologist and use them to generate a treatment plan, which is then eventually transferred to a linear accelerator, where the radiation is delivered to the patient daily in that same position that they were originally simulated in. The goal of all of this is to deliver a high dose to the tumor or target, maximizing our tumor control while trying to create a plan that limits dose to normal tissue as much as possible. So limiting the toxicity and side effects that the patient will experience due to the radiation to the normal tissue. So specifically for head and neck radiotherapy, we primarily have squamous cell carcinoma as the main type of cancer, and there can be many subsites for the primary disease, from nasopharynx to oropharynx to the larynx or tonsils or base of tongue, all different regions within the head and neck. And the patients will often undergo radiation therapy alone or in combination with surgery and or chemotherapy. They receive really long courses of treatment typically, so they are treated kind of daily for 5 to 7 weeks. So a long course with many visits to the hospital for the delivery of the radiotherapy. To give a bit of context for the number of patients just at Princess Margaret receiving radiotherapy, we have, courtesy of Sophie Wang, we have roughly maybe 650 patients a year. 520 of those would go on to curative intent radiotherapy, others receiving palliative radiotherapy, and you can see there a large number of subsites that may be treated at our facility. So more specifically for head and neck, if we go back to the workflow, once we have the decision to treat, the radiation oncologist will prescribe a certain dose of radiotherapy that we want to receive delivered to the target to create that tumor control. They'll then proceed to that imaging. And for head and neck patients, we immobilize them in a certain position so that we can recreate that treatment position each day throughout the course of treatment. And typically most centers use what is called a thermoplastic mask, and you can see it covers both the heads and the shoulders, helping to reproduce the setup every single day. And that will be placed upon them on the couch and deliver set up at the treatment unit as well. And you can see on the right here, they also would have a neck rest to help support the head and recreate the positioning of the head. These images, once they're taken, are transferred, as mentioned, to the treatment planning software. The treatment planning process itself can be quite tedious and time consuming, starting with contouring, going on to plan creation and optimization, evaluation of the plan. And this is typically a really iterative process with the radiation oncologist, the dosimetrist, and the medical physicist giving feedback to create a plan that will achieve that goal of target coverage while limiting toxicity where possible. So again, a reminder about the goal of the treatment. And that's really led, and first step is the importance of the contouring itself. So we have the treatment targets that are going to receive a typical prescription dose. A common one with radiotherapy alone or radiation plus chemo for our head and neck patients is something we call 70 gray. So that's the amount of dose deposited to the patient, ideally in the targets, in 35 fractions. So 2 gray per day delivered to achieve this total dose. And then we also have contouring of the organs at risk or normal tissue. So for those contours, we want to limit the dose as much as possible and potentially really respecting dose limits regarding safety for certain organs. So to walk through some of the contours and how we use them and what they mean, we've got an image on the right, which is a single axial slice or a transverse slice of the patient that you'll see on the CT images you receive. And we have a gross target volume, or GTV, is something that is shown in red. And this is a contour typically delineated by the radiation oncologist, and it's the disease that is visible on the images. That is then expanded. So the importance of these contours is really that they are often the base for other expansions that are used throughout treatment. So each time you expand the targets, any inaccuracies in the original contour can really propagate throughout treatment, showing how important the original contours can be. So these gross tumor volumes are expanded both geometrically and also with clinical information by the oncologist to create this clinical target volume. So that includes microscopic spread that might not be visible on the CT image itself. And then further in the treatment planning process, we expand that a bit further to something we call the planning target volume. And this additional expansion or growth in size from the green to the blue really accounts for uncertainties in daily positioning of the patient, as well as our machine uncertainties that may happen on the LINAC. So it's just creating larger tumor volumes that we will try and target with the radiation. I believe you'll see in some of the items you'll have some additional nomenclature documentation. So GTVP refers to the primary disease or the original tumor where it initiated. So this would be the GTVP. But we also might have, for some patients, depending on the staging of their disease, it may have spread to the lymph nodes, and this would be nodal disease. And we often call that GTV ends of different nodals. So some examples of nodal diseases for this patient would be contoured here as well. And each of those would have also a CTV and a PTV that are not shown here. So those are kind of the target volumes that really identify where we want to deliver the high dose to the patient to achieve clinical control of the patient and eradicate the disease. To give you a bit more of a kind of a slightly more 3D context of what these targets are, we typically have a head and neck plan, multiple dose levels as well. So I mentioned that 70 gray, but we have lower dose levels as well. And this just also shows the extent of the disease that we want to treat. So in orange, we have high risk target volumes, which receives the full prescription. In certain patients, we might have intermediate risk targets, which are receiving kind of an intermediate dose, and then often really large volumes that are receiving a lower dose. And you can see these volumes can be quite large, and you can tell we are covering a lot of normal anatomy close to that as well, which brings us to the importance of contouring the organs at risk. So now in these next few images, I have those targets now in a color wash, kind of overlaying where we want to deliver clinical dose to achieve control. And the contours that are not filled in are some of the organs at risk that we contour for head and neck, so we can assess that safety of the plan. And this gives you an idea of how extensive those volumes might be. To just give an example a bit closer, we've got an axial slice again here with those targets in color wash. And then we have some of the organs at risk contoured in the solid line. So we have the mandible, oral cavity, right and left parotids. We have one of the muscle constrictors here and the spinal cord. So why it's really important for us to contour these is to be able to just control the dose in our optimization and the plan generation, and also be aware of how much dose is delivered. We have, as I mentioned, kind of safety constraints for certain organs, and also it helps the radiation oncologist communicate with the patient about what risks or side effects they might have from their particular treatment plan. So for example, for the mandible, we would like to limit the high dose as much as possible because they could have long-term osteoradionecrosis or kind of death of the bone, or we could have factors affecting kind of locked jaw, depending on how it's done. Parotids are really important for generation of saliva. So you can have dry mouth and really impact quality of life if you're not able to spare those. So by contouring them, it allows us to find out what dose we will be delivering to those. Spinal cord particularly is one of those organs at risk where we really have safety limits. So in certain cases, we might have to, depending on the disease and how close it is to the spinal cord, we might have to compromise target coverage to ensure we don't deliver too much dose to the cord, since that could have long-term effects to the patient, such as paralysis, if we don't respect the radiation limits for that toxicity. So it's really important to be able to contour those so that we know how safe we are being. So as mentioned, kind of once all of those extensive numbers of contours are created, we'd go into that phase by the radiation therapist or dosimetrist of plan creation and evaluation. So they're using these contours, which then allow us to track the dose delivered in each target or organ at risk. So in an image for each voxel, we'll calculate the dose to that voxel. And by identifying it within a contour, we can assign and kind of track the dose that's being delivered to a specific organ. That allows us to define goals for our optimizer to create the plan we want that's specific to the patient and achieves those clinical goals. And it also helps us to evaluate the plan in terms of achieving that tumor control and the safety and limit toxicity if possible. So how we do that, one tool, for example, is what we call dose volume histograms, or DVH. So we are looking at a graph here of volume on the y-axis, volume of one of those contours that you'll be generating in the challenge, and we've got dose on the x-axis. So if we look first here at the PTV on the right, we want to deliver kind of a 70 gray dose to the PTV as much as possible. And we can use this to evaluate how we're doing and if we have hot or cold spots that we have to fix in the optimization. We can also use these contours to generate summary statistics of this and use the clinical goals to drive both the evaluation and that continued improvement of the treatment plan to get what we want. So we can look at each voxel in that contour that was generated and look at whether the amount of dose within that volume is what we would like. In contrast, for the organs at risk, you can see they kind of sit more on the left of this DVH. So we want to limit the dose as much as possible. And sometimes we want to avoid hot spots or maximum doses. Sometimes we're looking at different metrics. So just to pull out the right parotid here, we would like to limit the mean dose and kind of push it to the left, and spinal cord for that safety to avoid those kind of severe long-term effects. We'd like to limit the dose under 45 gray. So we really will push at the maximum dose to make sure we achieve. So this all of this is enabled by those contours that need to be accurate to best represent kind of the patient anatomy and allow us to create the best plan for the patient. And again, we've got different summary statistics that we might have for those patients so that we can do that assessment. So it's just using the information from the dose in the CT scan with the contours to give us different tools to look at those values and be able to assess how we're doing. So going back to the radiotherapy treatment, so we've made the decision to treat, acquired those images, contoured them, and used them for treatment planning. And now we're going to treatment delivery. And again, the contours play a role here. So the treatment, this is an example of one LINAC. The patient is put on the couch and they're imaged daily by the therapist before the radiation dose is delivered to make sure they're in that same position that we imaged them in for planning. And this is an example on the right of an overlay between the cone beam CT image that's acquired on the day of treatment, and it's kind of in green here. And we have the reference image that was that imaging acquired during planning, and it's more purple. So where we're white, we have kind of the overlay and a good match between the images, but we have some discrepancies where you see more green or more purple, where there's some variation in the patient from the time they were imaged. And you can see on here, we have again certain contours. So we have that GTV, CTV, and PTV, and also the spinal cord. And these will really drive the therapist to be able to match the patient and flag any concerns to the oncologist or the physicist to see if we have to do any further assessment or if we have concerns about how safe the treatment continues to be. So this is kind of a critical tool as well, those contours, in assessing the patient throughout the long course of treatment. So that is an overview of those kind of how the contours are used throughout. And I'd just like to comment briefly on some of the opportunities for auto segmentation in head and neck. So really, as you can see, we have a large number of contours, and that can be quite extensive and quite variable per patient, particularly for the targets, depending on how extensive their disease is. And there's so many variations from patient to patient, depending on what nodes are involved and where their initial site of the patient is. So the ability to auto segment these images really has extensive time savings in that first generation of the plan. But we also have a lot of anatomical changes throughout that long course of treatment of 5 to 7 weeks. So the patients can undergo weight loss or parotid shrinkage. Some of those are seen on the right here. We have a fraction 1 image on the left and fraction 35, so at the very end of treatment on the right. This is the same patient. We have one contour here in pink, which is some nodal disease. And you can see quite drastically the size of the patient has changed. There has been weight loss, and this is just inferior to the parotids, and they can often change shape, deform, decrease in size, really changing the dose that's delivered to these. So that is quite significant. In addition, this is another example with the tumor growth or shrinkage. So we have kind of a blue and orange overlay of a planning image and an image later on in treatment, where you can see there's kind of a drastic change or deformation in the target contours. So when we have this potential for change during treatment, it doesn't happen this dramatically in every patient, but really the ability to adapt our treatments to these changing contours and the changing characteristics of the patient is facilitated by replanning. But to replan and generate new plans, we again need to generate all of those contours that really reflect the current patient anatomy. And that's really another opportunity where accurate auto segmentation, which can be a challenge historically, would really help facilitate our process and allow for quick rechanging of the plan. Because really, as well, for head and neck, it's really important that we don't pause treatment at all. We don't want to stop treatment to wait for changes to be made to the plan. We want to be able to generate a replan as quick as possible. And really the automation there could be critical in allowing us to respond faster to these changes. So to summarize briefly, we have extensive numbers of contours, both organs at risk and targets in head and neck. And really these are critical for plan generation, plan evaluation, as a tool for guiding accurate patient setup. The final step of that as well would be for outcomes assessment, to be able to really track these targets and compare patient to patient. The uniformity and accuracy of these contours from patient to patient, particularly for the organs at risk, is pretty critical for us to be able to evaluate how we're doing and make improvements holistically as well. So really automation does provide a lot of opportunities for improved workflows in the clinic. And I'm looking forward to see the results of this challenge and how we move forward in the clinic as well. So that's it for now, and I'd be happy to answer any questions, or are we going to do those at the end?
We can save some for the end, but while Joe's getting his slides up and ready, I was wondering if you could make a comment on how long, on average, I know it would depend on the patient, but how long people spend currently contouring for a single patient case.
So it really depends kind of on the patient, but I think some of the radiation oncologists, just for the targets, could easily take minimum an hour. Sometimes depending on the extent of the disease, how much clinical conversation they need with other colleagues, could be much longer. And we also have kind of trainees and of different experience who are contouring. So that can add as time. So I'd rough estimate 1 to 3 hours easily, and that's just for the targets. In our clinic, we are very lucky to have kind of a dedicated individual who contours almost all of the organs at risk. So that is a clinical specialist radiation therapist, but it would take a few hours potentially to contour all of the organs at risk that are needed. And that can really, again, depend on amount of experience and the frequency that you contour that. So for smaller clinics where they don't have to contour some of these organs that frequently, that can be challenging. And I think we also have variability in confidence in contouring, different organs. So mandible, for example, is quite visible and easy to see, but the brachial plexus, for example, is a big challenge. And I think we have more variability there, and there's less people who are able to contour that routinely. So I think there's really opportunities there for improvement in uniformity and accuracy, and inter-observer, or we often use inter-observer, but inter-observer variability in the contouring can also be a challenge. So I think that would help us as well.
Perfect.
Okay, yeah, thank you, Dr. McNiven. That was a great segue into what I'm going to be discussing, more from how we can now use these cool tools made available by advances in computer science and computer vision to impact radiation therapy and begin to change this landscape that was discussed here. I'm going to just have a pointer on here. Here we go here, so you guys can see what I'm going to talk about. Just an overview of the talk here. And so as Dr. McNiven was discussing, there's a wide variety of roles that can be affected by AI in radiation oncology. And so, when the whole benefit of auto segmentation, it does automate really tedious parts of the pipeline, and it can be applied, as Dr. McNiven said, to automate and create different contours that will affect the jobs at every single level of this process. And so what that really means in a general sense is that a lot of these experts will have more patient focus roles, will be able to interact with the patient more frequently. And as it says here, with the hopes to witness faster patient turnaround times. And so the idea being that we can use AI to not only detect the cancer quicker, but to send this patient through treatment at an accelerated rate. And what that will do is that allows us to see more patients. And in theory, hopefully, if we treat patients faster, that means the overall survival for that treatment, if the standards are kept at the same level, will be better, which is what we want. And so just an overview of the AI segmentation methods that have been published in this space. So really, the onset of deep learning didn't really begin until 2015. Before that, there was a technique called multi-atlas based auto segmentation that really used physics and deformation to really adjust contours from a new patient. And it was basically applied. There was a collection of patients that used to make a general image consensus where new contours will be deformed to. And so now that in 2015 was in 2015-2016 era, with the advent of UNet, was replaced by convolutional neural networks, which a lot of you guys know about because that's what you should specialize in. And obviously, as discussed in the technical session, these networks can be used to detect and really detect class values at the pixel level, which is perfect for auto segmentation, especially in terms of radiation therapy, because there's a lot of different volume classes that we want to segment for radiation therapy. And so it wasn't until 2019 that the first open source study to actually release their code to the community was published. That was AnatomyNet. And further in 2020, the largest training set to date, about 3,700 scans, was used by this group to segment 16 head and neck OARs. And most recently, the state-of-the-art used NAS, or neural architectural search, to segment 42 OARs on a data set of around 700 patients. And I just would like you to note all these data sets used for these studies, they had consistent number of patients and consistent number of labels present within their data set. And so that is a standard that has been a standard method of going about training these networks, is that all the labels for each and every organ class that we have in the data set have to be conserved. But that's a question that we want to kind of tackle using this challenge. And so just a little bit more about the data set. So the data set we're going to be diving into is called RADCURE. It contains about 3,000 head and neck cancer patients. Currently, this will be the largest data set to be released to the public to date, and it is in the process of being approved and configured to be released on TCIA very shortly. And there are multiple phases for this data release. And so for this specific, and so as you can see here, it covers annotations for dental artifact detection, GTVs plus the clinical data, and OARs for auto segmentation. And phase 3 is what we're going to be dealing with in this challenge here. And so just an overview of the key components for reproducibility of AI models. So yes, the data set that we've extracted, so we have an in-house tool called MedImage tools used to kind of extract all the contours and imaging data used in this analysis. And so really the raw data, we got that in DICOM format. And so what happened was basically this script parses the DICOM files and the DICOM contour sets in order to extract the data. And so the data that you see in the RADCURE vector folder, you can find that RADCURE vector folder. If you have access to the H4H on vector, you'll be able to see that the imaging data is given to you in terms of a CTV image, and there's a folder with all the structures. And now one thing I would like to note, the current way that it was extracted conserves the spatial settings of the original patient. So if you want to standardize the spacing in your scripts, separately, you'll have to do that separately. But I just, when we extracted it, we just gave it as is, normal spacing as seen in the current patient image. And the reason why we wanted to do that, because when reapplying these contours and embedded them into back into RayStation for planning, we need to conserve the spatial dimensions of the patient in terms of the XYZ planes. And so all this was taken care of, and you could read the paper that Matea linked to. But basically what we did was we packaged this all into a very, very easy reproducible way using PyTorch Lightning software environment. And so that is accessible on GitHub. And so that's kind of a nice overview of kind of how we can keep everything reproducible. And I'd like to stress that when you make your code, there's boilerplates in that GitHub repo that we talked about in the technical session to help you standardize everything and make it very clean so that inference is very easy for us. And so here's a list of all the well, some of the organs at risk that we extracted just for you, just to see the immense work that was done to kind of standardize the naming conventions here. And so you can see that there's a whole lot of variations in namings in terms of the medical data. So because the data set ranges from 2005 all the way up to 2017, 2018, before the naming conventions were actually standardized by a global consensus, the doctors would just take to name the regions of interest on their own. And so there's a lot of naming conventions. And so that was the first step in really extracting the structured data, was really to standardize the naming conventions for all these different OARs at the same time. And so when we look at, as Dr. McNiven said, there's a lot, radiation oncologists, I mean, we could divide these OARs into different categories by their radiological characteristics, as well as the complexity of contouring each individual OAR. So there's OARs which are very simple and, you know, to segment in terms of, for example, the eyeballs, the brainstem, and the parotids. But there's also some OARs like the brachial plexus is seen here, the optic chiasm, that are more difficult to segment. And this is because it's very hard to see these OARs on the CT imaging. And so even for radiation oncologists, the inter-observer variability when segmenting something like the chiasm is very, very low when you look at a DICE value. And so obviously this is something to keep in mind when actually thinking about clinical acceptability. So a very low DICE for a chiasm might still be clinically acceptable because as a consensus, doctors are variable in how they define that specific organ at risk. And so to move on, we see that in terms of AI, in terms of reproducibility, in terms of what research has been done already, a lot of papers that have published models are not reproducible. So one of the 15 studies published from 2017, we could actually reproduce in further analysis. And that actually is a big flag for us. And that's why, you know, one of the main reasons why we started this challenge was to build systems that we could release to as an open source code to the community that would help accelerate OAR segmentation as a whole worldwide. And so this is an overview of what was done, our model of choice that we will give you packaged, that you probably have access to if you kind of clone that GitHub repo. But basically, we ended up doing an ensemble with a basic unit type architecture over 580 patients or so, and we built that ensemble. It was a 5-fold cross-validation. And so basically what happened was we trained this simple network, we made the ensemble, and we applied it on 6 external data sets after it was finally trained. And so just a brief overview of what those results look like. You could read the paper in more depth. But basically, we did fairly well across all OARs that we segmented, the ground truth being at the top, prediction being in the middle, the difference being here. And we could see that the less stuff we have on this slide, the better. That means our network does quite well at segmenting OARs right off the bat. So in order to beat this, you guys are going to have to do some more advanced techniques, or maybe not more advanced techniques, but you're going to have to put some work into beating the baselines that we've already made. And so just a performance on the RADCURE dataset to show you guys what you should be expecting when you're segmenting organs at risk like this. I just want to focus on this green box area. So generally for inter-observer variability, if a contour lies in this green area, you could infer that it should lie within the relative range of inter-observer variability and between radiation oncologists. So that's a DICE above 0.7 and a Hausdorff distance to lower than 3.5 millimeters. Now this threshold will change depending on what organ at risk you are actually looking at. And so just for the sake of time, I'm not going to be discussing what we did good at. I'm just going to look at what we did bad at, what we need help with. This OAR, as you see here, the optic chiasm performed it looks like it performed very poorly, but as I said before, the inter-observer variability lies between 0.4 and 0.6 DICE when clinicians actually delineate this contour when we have multiple observers between clinicians. So this is actually right within the clinical range. Right off the bat, RADCURE could, so our network could indeed inject chiasm contours into the plan, and these contours could be clinically acceptable. But when looking at the external data sets, here's a dump of the results on the external test sets we see here. And we see that our network had some issues in terms of specific OAR categories. Chiasm did standardly poorly. Other organs at risk like the acoustics, and one of the main reasons the acoustics did poorly was because the acoustic contour is very variable in how it's delineated from center to center. So that will affect the performance of your model when we apply that to external data. So I just want you to be aware of that. There's different ways to contour the acoustic contours. And so in RADCURE, it's relatively consistent, but when you apply that to different data sets, you'll begin to see that the variability affects the performance. So fine tuning might be necessary when basically applying these models on external data sets. And finally, the optic nerves over here, we did kind of 0.6 is fairly decent. Clinical acceptability thresholds should be around 0.7 area. So we can have room to improvement in terms of the optic chiasm. And so when looking at what we did good at segmenting the mandible, brainstem, eyeballs, and parotid. So if you're doing bad at segmenting that off the gate, that's not a good sign. So you should be doing good at segmenting at least these right off the bat. We performed poorly, but not necessarily may still be clinically acceptable at segmenting acoustics, optic chiasm, and the optic nerves. And the reasons for this are there's smaller OARs, there's variability in how doctors contours these OARs, and these are just smaller than average organs. And as we can see here, that for most of these data sets what we applied to, we achieved at the level or higher than inter-observability thresholds for individual organs at risk. And so that's kind of what we want to see in order for the network that you guys produce to be injected into the clinic. We want to make sure that it at least meets the threshold of inter-observer variability. But obviously, when the whole clinical acceptability discussion is for another day, because we could spend another hour talking about that. And so just to give you an overview of all the regions of interest in RADCURE, this is going to be your issue here, and this is going to be the fun part about this challenge, is that we have a data across all these 3,000 patients, but one of the main issues is we don't have all the labels for all the patients. And so this is where you come in. The whole goal of this challenge is to create systems that can learn from all the data that we have at our disposal. And before, technical problems, with this would be, for example, class imbalance, right? Because, you know, if you have lower labels for, let's say, the muscles in the neck region, then let's say the brain or something, that is one class imbalance problem that you have to deal with. But another class imbalance problem you have to deal with is the amount of voxels the specific OAR covers. So just to keep those two issues at the forefront of your mind, your network should be able to leverage these labels across all patients to segment all 34 OARs that we have listed I don't know if, Matea, did you send them that list of OARs?
That has not been sent to them. That's something that they can look up in the data set as they go through it.
Right. So there's going to be a whole bunch of, and we can see, I could tell Matea to send up, but basically in terms of what these OARs are, in the GitHub repo, you'll be able to see a list of them because I do have that list ready for you in the GitHub repo. So you can go avail yourself at that. But the whole goal would be to segment each and every one of these regions of interest automatically using all the data that we have at our disposal. And so as I said here, this is just another overview of that same image here. When we don't use all the data, this limits the questions we could answer. But when we use all the data, what in turn it will make more robust models that will have a greater impact when we inject these systems into the clinic. And that's what we're all about here at CDI. We want to really take the models that you create here and inject these into the clinical practice at UHM, which is very important. So I hope that gives you a good kind of sense of the overview of why you guys are doing what you're doing.
Perfect. Thank you, Joe.
No problem.
So you both have hinted at this inter-observer variability. So different clinicians contouring the same thing, but slightly different. From a clinical perspective, is it optimal to have the exact same thing contoured? So say we're to have an AI contour everything at Princess Margaret, is that preferred over the consensus, or do you still think the consensus is important to reach? So do you ever envision an AI being a standalone, or is it always going to be a decision support?
A bit different for targets and organs at risk. So I guess one thing we didn't mention is really for the targets. I think a challenge with the AI technology is that when the ROs or the radiation oncologists contour, they are kind of in their practice not just using the CT data. They are often also using clinical knowledge and clinical exam of the patients and some, knowledge of exactly kind of on the, for example, mucosal surface that they can visualize with a scope, how is the target spreading? And they can incorporate that into their knowledge as well. All of the targets, so those GTVs, CTVs, are peer reviewed, so they go through peer review. And since that is so variable from patient to patient, I think AI technologies that could aid in that process would be great. I really do think it will be a challenge to get contours that the ROs are fully clinically happy with without that additional review. So I think my gut instinct says it's kind of that way for targets. I think for organs at risk, I think for the most part, I think AI will be able to get us there. I think that the challenge is, I think we've come a long way over those kind of 20 years or whatever the data set is from. I think we've seen a lot of changes in our clinical practice. So, standardizing the nomenclature to facilitate better chance for kind of radiomics or other kind of bulk data analysis or big data analysis is coming along. And I think there is improved consistency in terms of how those are contoured and consensus guidelines on how to do that. But there is still variability. And often too, I think another challenge would be kind of in a post-surgical context. For example, we might not have these organs even existing in certain patients. Maybe they've had a parotid removed or whatever. So I think there is always going to be trouble spots and potentially kind of a review, but I think AI kind of out of the box, and many people are using different segmentation tools with manual editing in clinical practice in different ways. So I think hopefully any improvements will get us closer and minimize that tweaking. And I think further analysis of how kind of those dosimetric factors, like to a certain degree, especially even with kind of mean dose metrics, small variabilities really don't impact our assessment. So I think small variations or tweaking and understanding when we should stop tweaking based on like clinical kind of impact or knowledge could be another thing that we could look at in the future. Hopefully that answers a bit, Matea.
Nope, that does. That's perfect. Anybody have any questions?
I had a question for Dr. McNiven, a clinical question. I just wanted to ask if is it common practice clinically that the same person does the contouring throughout the treatment, or is it interchangeable, like in terms of the segmentation or the contouring itself?
It's potentially variable. So really for most of the patients, they're really just contoured kind of before treatment with that CT scan. And we just use those to look at images each day. And then it's if we think there's a need to replan, imaging occurs again, it would most often and ideally be the same radiation oncologist who contours all of the targets, because they are most familiar with that patient, and really there's time savings for that in our kind of crunch clinical timelines. But if that radiation oncologist happens to be away or something, then another radiation oncologist would contour that patient. So there is variability there, and for the organs at risk, it could be anyone, depending upon kind of the clinical workflow. And I would say, it's pretty unique currently at Princess Margaret that the majority of the organs at risk are done by kind of one individual whose focus is delineation. At most centers, it would be the team or an individual dosimetrist that would do all of the organs at risk, with review by the radiation oncologist after to kind of ensure accuracy or acceptability. So quite variable.
Anybody else? So we will be, since this is being recorded, we will be posting this on the Slack channel for all of you to see. So if questions pop into your head later, you can let us know and we can try and search out some answers for you.